Hi, I'm Dr. Terry Hanlon. I'm currently the acting medical director at Creekside Hospice in Las Vegas. I'm going to be talking to you today about an important subject. I'm going to talk to you about hospice diagnoses and relatedness. For our objectives, we're going to try to avoid mass confusion ahead, and that's coming May 1st, 2014. With the new relatedness to Medicare and Medicare Part D. Our objectives are to determine the hospice diagnosis, what is the primary diagnosis, the secondary diagnosis, contributing comorbidities, unrelated conditions. We'll also discuss how to do adequate medication therapy management and go over the hospice formulary, and together these two will help us determine coverage for the patients. So what we're really talking about is not a new rule. Back in 1983, when the hospice Medicare benefit was first started, it said essentially what they reiterated in the COPs, that all drugs and biologicals related to the palliation and management of the terminal illness and related conditions as identified in the hospice plan of care must be provided by the hospice while the patient is still under hospice care. And then if that wasn't enough, then it was reiterated in 12 of 13 in a memo from CMS. As a general rule, hospice providers are expected to cover virtually all drugs for hospice beneficiaries during the hospice election. And then from the Federal Register, we're told that the hospices should start reporting on hospice claims all coexisting or additional diagnoses that are related to the terminal illness. They should not report on additional diagnoses that are not related to the terminal diagnosis. So, how are we going to figure out what to cover? To help determine coverage, we need to clearly define the hospice diagnosis. The one we're most concerned about is the primary terminal diagnosis. It's the clinical condition determined to be primarily responsible and most contributory towards the terminal diagnosis. And it's also the diagnosis that we use for the hospice patient's admission. We used to be able to say general things like LCD categories, end-stage heart disease. We are now looking for specific diagnoses, especially with the ICD-10 coming out. We will need to know these different categories. So, say for instance, we determine the patient's diagnosis to be ischemic cardiomyopathy as his primary terminal diagnosis. Then we go to secondary or related conditions. Secondary conditions or related diagnoses are associated with the terminal illness, interconnected with it, and impact prognosis. So for a diagnosis of ischemic cardiomyopathy, it would be things like coronary artery disease, AFib, and CHF. So if the patient totally fits the criteria, LCD criteria for end-stage heart disease under ischemic cardiomyopathy, you may be good. You don't need any other qualifying diagnoses. But for most patients, these contributing comorbidities, they may be unrelated to the primary diagnosis, but they can help contribute towards the patient's terminality or terminal prognosis. They usually involve major organ systems like end-stage liver failure or end-stage renal disease. And since they contribute to the patient's eligibility, any drugs used for these conditions would be the hospice's financial responsibility. So in our patient's case, if he had diabetes and hypertension, these would be contributing comorbidities. So for relatedness, again, to reiterate, all services are going to be considered related unless the hospice MD documents why a patient's medical needs would be unrelated to the terminal diagnosis. And how are we going to get to that determination of relatedness? We're going to do this through medication management, and we're going to accomplish this as a team with the interdisciplinary group in collaboration with either the pharmacist or the hospice medical director. What are the unrelated conditions then? These are conditions or diagnoses that are independent of the terminal illness, is not related to, and does not impact the terminal prognosis. These conditions should be documented in the clinical record, but not included on the claim form or the certificate of terminal illness. And those kind of things would be like glaucoma or hypothyroidism, osteoarthritis, minor sort of things that may impact the patient's function, but not necessarily their terminality. And just to talk about a couple important diagnosis categories, debility and failure to thrive. Debility and failure to thrive should not be used as a principal diagnosis anymore on a claim form. This actually won't take effect till October 1st, 2014, but I believe it should start now. We should start reviewing our charts and coming up with alternative diagnoses. It may, however, be used as an additional or coexisting diagnosis on a claim form. And there's a couple go-arounds with the ICD coding, but you just need to remember that you have to focus on what diagnosis is the patient's primary diagnosis, and then if they have debility, you can use that as a backup diagnosis. For dementia, it's going to be one of the new targeted areas, as well as cardiac disease. So we want to be as specific as possible with the proper coding sequence. You want to code the underlying condition first. So in the case of multi-infarct dementia, you'd want to code atherosclerosis first. And don't use dementia classified elsewhere, dementia unspecified codes, unless there's associated behavioral disturbance. And particularly important with this diagnosis is to remember little tricks like FAST 7B, all intelligible speech is lost. You score FAST at the highest remaining level of functioning, and the loss of ability to walk must be due to dementia. So if this is what your face is looking like right now, you're cross-eyed and you're not really sure which way to go, I want to reassure you that there is a way to make sure that the patient gets the right drugs and they're covered when appropriate. And the way to do this is through medication therapy management. This involves doing a thorough medication reconciliation, medication therapy review, a complete pharmaceutical care plan, determining who provides the medication, and then close monitoring and follow-up. So what is a medication reconciliation? Well, if you're a hospice admit nurse or working in the field, for you it's probably going to be a Ziploc bag, gallon-sized, filled with a bunch of medications that the patient has no idea whether they should be taking now or not. So your job is going to be to compile all this information from the medical records, from the patient and their family, and their shoeboxes and bags of medicines, and determine what prescription medication they have been taking or has been prescribed, what sample medication that they have, and also include the vitamins, the minerals, the herbals, the nutraceuticals. These are important. They're not FDA regulated, but they can impact the patient's symptoms and drug metabolism. Any non-prescription medications, they need to be on the patient's pharmaceutical plan of care also. Are they up to date on their vaccines? Any inhaled, injectable, or topical medications are important also. And why do we do this? A large part of it is for the benefit of the patient, They've been to so many different doctors by the time they come to us, and so many different hospitals, and have so many lists of medications that we need to be the one to bring it all together. So these reconciliations should be done at every transition of care, but especially admission. That's when you need to take all the information from all the sources and try and bring it together. Once you have that done, it also needs to be done at changes in settings, service, practitioner, or level of care. In addition, the medication should be reviewed at every IDG. My suggestion would be that while you're doing IDG, that you have 2 computer screens set up. One for you to do your notes and certifications and patient information in, and the other one set up as a screen that you can evaluate each patient's medication and whether or not they're appropriate. This will help avoid medication errors. So we're going to focus on doing a medication therapy review. This is going to be to identify and prevent medication-related problems. We're going to determine what's called medication utility or necessity. And then we're going to possibly identify orders that need to be changed. The term medication utility refers to whether a medication is useful in a particular individual in a particular clinical situation based on both the attributes of the medication and those of the recipient. So it's pretty simple. We either decide that medication is necessary, unnecessary, or sometimes it's a gray area, uncertain. Medication use in hospice is complex. These are patients with often multiple diagnoses who've had polypharmacy, who've had polyproviders, and inappropriate medication use is prevalent. These are often elderly patients with fragile health who may be affected by the dosage that's normally used and other things, such as organ system dysfunction. As they decline, their liver clearance of medication and their renal clearance of medication may be affected, and the dosages would need to be adjusted. They also have a short life expectancy. And what does that mean? Well, without sounding too blunt, they may not benefit from some of these medications that they've been on for chronic long-term illness. We're looking at the time to benefit. So for our patients, we're really concerned with the minutes to hours comfort, like analgesics. The things that go on for months that you don't see anything, like the bisphosphonates, or even years for the statins and even tight diabetic control, we're not as concerned about that.